for those who don't know me, my name is Evie, and I'm one of the ST8 ICM and Fed trainees. So I have recently completed the Associate Principal Investigator Scheme, and I just thought about, like talking a little bit about what it is, how you can do it, what are the eligibility criteria, what I think that's, like everyone is getting out from it. And hopefully I can convince some of you that will stay here with us for 6 months, maybe to become the next PI for the Mosaic study, because that was a study that I was involved, all right? So in terms of the Associate PI scheme, what it is, what it entails, it is an opportunity that you have when you're going to be in a place like for 6 months. It provides you with some practical experience, especially not only doctors, but also like nurses, that they can have some research experience and build up on their research career. It is for people that they're not like academics, they don't do it, like on the day-to-day practice, but they like research and they want to be involved with it. You're going to have the chance to experience what it means to work and deliver a study, and to have also, like a very good working relationship with the research team that we have here, and any associate, any principal investigator, consultant who you will be working with. In my case, I was working with Mega, who has been absolutely amazing and a treasure. And the principal investigator was Dr. Whitman. So, of course, at the end, you're going to have a formal recognition of what you did. You're going to do a little bit of work. We're going to say what that is, and you're going to get also a certificate at the end. This is all recognized by the Royal Colleges and the GMC. So that's good for your portfolio as well. In terms of the eligibility criteria, as I said, any qualified NHS health professional, doctor, nurse, midwife, pharmacist, can take place in that. You can also have from foundation year 1 trainees and above. So if someone is in FY2, they could do that. You can only be an associate PI for one study at a time. But it can be, for example, that for the same study, you have more than one associate PI, which makes it actually easier for the running of the study. You have to be able to commit for 6 months in a study. So it's ideally when you're in a place and you're going to have rotations that will last, like 6 months. Or even, for example, if you're here in intensive care, you're 3 months here, and you're like 3 months in theaters, for example, or 3 months on the medical wards, it can still be done. Okay, so this is something that it's not that I wouldn't choose to do it just because I'm not going to stay in intensive care for 6 months. And of course, the way I was told about the PI was through Dr. Whitman. So, like you have to have a principal investigator that you're going to talk to them, express their, like your interest, and then they will agree with this and you will proceed further. So while you're doing all this scheme, you're involved with research, and at the same time, you just have to keep, like a checklist of what you're doing, because this is what you're going to use at the end in order to sign off and get the certificate. So first of all, you yourself, you will have to undergo training for the study that you're involved with. You will have to sign the delegation log, right? We're going to talk about how you can do the training a little bit later. You have to help the research team and the PI and disseminate the study in the department. This can be done in a lot of ways. So you can send emails, like through the secretaries. You can put like small posters on top. You can just go and talk to people and just be like, please help me, like a little bit like that. Try to keep a diary also of every meeting that you will be involved with, because there are different meetings that you have to take place. So there are, like different parts of the training. It's different for the randomization. It's going to be different for the consent. So all this, you need to have a diary in the 6 months and be able to prove what you did in each of those months. You will help with training other staff. You'll have to make sure that they have, like their GCP training if it is required, and for the stages that you're going to be involved with. and train them for the protocol of the study. You're going to help the PI in every, like way you can. And as I said, this is something that you will just have to evidence it every month. Okay. How is the process? So you can see a little bit here. I know that the letters are very, very small, but if we can just split it, it can be done. So first of all, you have to see if you're eligible. So think amongst yourself, am I eligible? All right. If you are, then you have to find a study that you're interested in. Hopefully today we're going to convince some of you to just be involved with some of the studies. Then you will have to do an application form through the NIHR. You're going to do some online e-learning. You're going to do everything that you need to do for 6 months. We're going to complete the associate guided checklist, and then at the end, you're going to have signatures, right, from the study, the investigators, and your PI, and then you're going to get your certificate. What are the benefits? There are multiple, like there are for you, there are for the team, for the study, for the patients, and the PI. So from my perspective, what I found very, very interesting, I really, really enjoyed, was that you get an experience, like you get the understanding of how research works. You are involved in this. You have to do some further learning while you're doing all the associate PI scheme, meaning that you will have to read a little bit more about the different kind of research, how like you critically appraise, for example, like the evidence. You get to work with the research team. I said it is really, really important. This teamwork, you're building that, and you are going to use it in the future. You can lead things, so it also helps with your leadership skills as well. All right. You are going definitely to boost your portfolio, unless you're like an academic. I think that this is the best way you could do it in order to tick that box, okay, that you will need for ARCPs and even for your consultants, like jobs in the future. And you're going to be acknowledged in every sort of like publications that are going to come out of that. So that's also an easy win, really. In terms for the PI, so for Zoe, it's just that, like you help. They have a lot of burden, like on them. So you really help them do this. And that's it. It's an additional support. In terms of the study and the team, I feel, I don't know, like correct me if I was wrong, I feel that it helps when you're the associate PI because you're close to you guys, the rest of the trainees, the rest of the doctors. So you have a more like daily interaction with them. So it's easy to coordinate things. It's easy also to allocate, like roles in your team and make sure, that nothing is missed, definitely through randomization. Okay. And for the patients, they are going to get something out of it, because at the bottom end, what we're doing is we're trying to make high quality research, high quality evidence in order to make the care of our patients better. Okay, so this was it. I said that it would be something very, very fast. This is the QR code in case you're interested in this. We will continue with the stands that we're on here. I really, really, really would love some of you to come and just talk to us, right? It's us that are going. I'm going to speak for the Mosaic study. Joe here is going to introduce yourself and what you're.
I'm Joe. I'm API for nuclear arts.
So yeah, not much.
And
a couple of studies upcoming that haven't got APIs yet.
So just see all the studies that we're doing. Find one that you're interested in, and then come and grab us, and we're going to see about, what do you want to do? How much do you want to be involved? Do you want to be the associate PI? Do you want just, to be involved in order to recruit and get, certificates for that? Okay, so you choose that, all right? I really hope I'm going to convince you to become the next Mosaic PI, okay? Good, perfect.
The research nurses wanted to.
Hello. So my name's Jade. This is weird because Mega is the research nurse for ITU and today is her last day. So yeah. So Mega has been amazing brilliant at her job, and everyone will tell you that. And she's, you know, you guys are really research focused up here, which is really lovely to see. And as of Monday, it's over to me with Jess and Sue. So we've got somebody to choose to fill. So yeah, so as of Monday, it will be me, and Jess is another research nurse. Jess works on a lot of early phase studies, so that's her kind of bag. And then Sue is quite new to our team, but she's not new to ITU, and she works for like decades. So yeah, so she's a really good person to ask. I'm not, ITU is not my background, I'm an A&E nurse, so I'd say just shout if you want a hand, but I probably won't be able to help. But if you see Sue will be able to help you.
You're all going to be awesome.
Yeah, so yeah, so that's just to say, you can't really see it, but we're the research team. We live downstairs and we're part of the research space. But as I say, we'll be out. I can share these slides with everyone, and it's got our details on our email and our work numbers as well. What's next? Oh, so you might not be able to see this very well, but basically this is a little slide about what we do. So we work in the research space, and the research space cover lots of different specialities. So obviously we have A&E, ITU, infection, and then the other side of the team are kind of rheumatology, hematology. So we work across a lot of different specialities, but for me, mine is A&E and ITU. Everything Mega was ITU, you know. So but the other things that we might do as research nurses is work on kind of vaccine studies. So if we're not around, it's probably because we're doing some kind of early phase vaccines downstairs. So what we do in this trust is we're a delivery site. So researchers and sponsors will contact our teams and come to the trust, come to the consultants and ask if like we can deliver their research. So that's what we do. And as I say, up here you're really research focused. So there's a lot of studies, which everyone will go through later, going on. And I'll just do all of these bits. So part of our job is to make sure that we go through it. So it's quite a long process to get from an expression of interest. So when we first hear about the study and the consultants will say, yeah, we can do that, we can do the PI, to actually getting the green light to start the study. And we have to go through feasibilities and make sure that we have enough patients that come onto the unit that will be able to go on to the study, or do we have enough staff that are going to deliver the study properly? So we do a lot of that, and then we have to also make sure that we are following all our legal and the ethical kind of guidance around research. And so when the research study starts, that's our job as well, to make sure that everyone's kind of GCP is up to date, everyone has their research team. When somebody's recruited, that all those boxes are ticked, or not ticked, initialed, and everything properly. See, I'm learning. All these things are done properly. So that's part of our job, that we're just there just to make sure that it is. Obviously, as I say, I'm quite new, so we'll be doing it together. And I suppose the most important thing we do is that we recruit. So we'll it's a little bit different up in ICU. So you have research without prior consent. So we can recruit patients in an emergency situation on studies. For example, in A&E, I don't have that, so I have to gain the patient's consent, or the relative, or the professional consent before we could start. So yeah, there are differences between different specialities, but we will consent patients, and then what we do is, once the patient's on the study, we'll support with data collection. So we'll come up every day. I've not done many yet, but actually most of the data collection for patients on ITU are every day, and we'll be there with the big charts looking normally for 28 days and things. So yeah, there's a lot of data collection that goes on once you guys have done your bit in recruiting the patient. And so yeah, so we need your help. So there's a few different ways you can help. So you can either refer patients that you think could be on a study to the PI or one of the APIs or one of the clinicians that's delegated, or you could give us a shout if phone, or don't email us because we might not see it, but yeah, phone or text or something like that, and do it that way. So just be aware that when you're reviewing a patient or you have a new patient or you're missing someone, is there a research study that might be appropriate for this patient? And if it is, let's tell someone about it. You could go a little bit further. You could join the recruitment team. So that's a bit about like what Emmy was saying. So that would be getting delegated onto the study. So for that, we would need you to complete your GCP training, complete the study training, and like create a research CV and bits like that. And once you've done them, that's great because then they last for a couple of years. So, and that just means you'll be able to actually recruit onto the study, and you'll be able to then randomise and consent and things like that. And then the other thing is the API scheme. And that was it really. That's us. So yeah, you're kind of meeting us at a bit of a changeover. So yeah, bear with us. And yeah, but we're here, and we're looking forward to working on it.
For pretty much any of you in training, the one of the generic professional capabilities is related to research in pretty much all curricula, whether it's ICM, anaesthetics, medicine, will have a number of competencies based in research. So this could be a way of evidencing those. They're not always leading to evidence, so encourage you to get involved. We can do certificates if you get involved in randomising, or certainly if you've been involved in something more like an API, then we can get you involved to help fulfil that list for curriculum.
I know you're not here for some people aren't here for very long and then you'll rotate, but if you do your GCP training, which I think takes about 4 hours, it's supposed to take. But once it's done, that's it. I think it lasts 3 years. Your GCP is 3 years, and then your research should be 2 years. So if you did that now, and then you rotated, say to A&E, I could come and ask you to work on the A&E studies, or if you go to medicine, like we're also doing aging studies on the elder people's ward. So yeah, it kind of stays with you, and then you can be involved in other rotations.
If you Google NIHR and GCP, it's an online e-learning module. Just do.
That's us. So yeah, we'll be around, and
Trying to make a shoes. Yeah.
Hi, my name's Jo. I'm one of the SC7 trainees here, and in case you haven't already figured, I'm really unhinged. I can't help it. And I have 2 talks today. One is like a little bit of an intro to research in intensive care. What is it to do with you? Because my second slide is I'm not an expert, and I've always thought I'm really not a research person. But actually, if you spend long enough in medicine, you'll realise actually research really is part of what you should be doing every day. And if you can, then you should also take part, an active part in research as well. And that's what this afternoon has got to do with. So what has research got to do with all of this? What we should all be doing is interpreting available research in all the decisions that we're making. So this could be as simple as following the hospital guidelines, which are, believe it or not, evidence-based. And the best hospital guidelines will also have an appendix of where they sort of like reference where their decisions are made, or they'll give a little bit of backup. Why do we thrombolyse when it's a massive PE? Because there isn't mortality. Why don't we thrombolyse on massive PEs? Because there isn't benefit. That's all research-based. If you haven't got guidelines, if you've got a really niche question, then you start typing things into PubMed, start looking at things that are up to date. So that's us using research to inform our decisions. And then obviously we are also here to take part in research. This is just a couple of slides to when I said, so if there isn't a bond or guideline to guide the decision that you're making, like thrombolyzing a PE, which is sort of like a really final decision. What about whether we filter or not in pancreatitis? That's like really, you ask 10 different people, 10 different people will do different things. So if you go and look for a paper, then how do you decide whether this paper is relevant to you? And that's called critical appraisal. And this little table here is just one of many frameworks that you'll find, which I reference in the end, whether that paper is relevant to your patient group, whether that paper is a good study or not. and whether actually they're just making their numbers up. Quality numbers are actually getting better, even on ITU, which means that if you're actually, even if you're looking at mortality, you're actually needing larger and larger patient numbers to adequately power your study, which means that you then need your studies to take over years and years and years. And over years and years and years, practice changes. So actually you'll find that studies that were done without answering the same question at the beginning and the same study done 5 years later will have different results, because in those 5 years, things have changed. A prime example of this is Rivers 2001 was what quoting papers now to make myself look smart. No, I learned these for my exams and they're still etched into my memory. Every smiling. Rivers 2001 is one of those early sepsis studies where they were like, oh, you stick central lines and transfuse everyone, you're making massive mortality difference. But actually, like 5 years later, 10 years later, they tried to repeat it and they couldn't make that mortality benefit. And the reason was because everyone started giving antibiotics, and that was actually what made the difference. So needing large numbers, studies taking over time, makes it really difficult to get a positive study. The other thing that makes it difficult is actually what are we comparing to and from, and you'll find with a couple of the studies this afternoon, this problem comes up as well. So for example, blood transfusion, what should our targets be? So we are now all quite used to 70 as a target. One of the earlier studies was comparing 70 to 100, and 100 seems like wild and like beyond reasonable. And back in those days, yes, 70 did a lot better than 100, but actually the studies after that compared 70 to 90, and there was no difference at all, but we still sort of 70 is cheaper. And then is this the final thing? Possibly the final thing. What condition are we even talking about? Like I said, we need big numbers to make studies work, and especially there are some conditions in ITU that everyone has. For example, not everyone has, but they're very common conditions. So ARDS and sepsis are big umbrella terms, and we try to study them. And the problem is that you will see, as you see more sepsis patients or more ARDS patients, are massively different. So again, to prove any mortality benefit is really difficult. Instead, unless you start doing the subgroup analysis, like only neutropenic sepsis patients under the age of 65 will benefit from, I don't know, vitamin D. And then by the time you get to that level of subgroup analysis, your numbers aren't really good enough. Ethics of patient, I think this is my last one, I hope so. Ethics of patient recruitment. So most research trials, you'll know that you need to consent the patient to have a different treatment arm from what is considered best practice. But in ITU, most patients are either obtunded or sedated. So what is the ethics of that? So most treatments, you'll either have to sort of waive the ethics and say, actually, we can recruit the patient without consenting. And that's a really high bar to reach. You can't start throwing, I don't know, think of something, caustic soda at patients without consent, because like ethics would never clear it, which means that that limits the number of studies you can do. Or if you do a study where you do need the patient to consent, then actually you've got introduced sampling bias, because only patients that are well enough and are willing to consent are going to end up in your study. I've already said that. Solutions. So what are the solutions to all of these challenges to research in ITU? Number one is adaptive trial designs. So randomized, singular randomized control trials, like I said, take ages and ages. Adaptive trial design.
Unless there was some top recruitment.
Larger multinational. Observational studies, that's a bit of a contentious one. There's lots of ITU patients, lots of data, actually just have a look and see what seems to work. Shared agreements are in regulations, so multinational studies, different countries are going to have different regulations. GDPR in Europe apparently threw a lot of sparrow in the works. That's what my internet reading told me. Useful resources. So that little table that I had about how to critically appraise a paper came off the CAST checklist for critical appraiser website. The bottom line is a really, really good website for sort of summarising ITU trials so that you don't have to read the paper. I'm guilty of using it a lot. Up-to-date Dynamed for those sort of summarised guidelines, but also with evidence. I think it's been mentioned a couple of times, introduction to GCP, that's like a four hour sort of e-learning thing that just basically teaches you the basics of research. E-learning for health for anaesthetic training to masters. There's a research module, do it. Upload a certificate, tick.
So also, if you want a quick sort of guide to the research in a particular area, there's a website called Life in the Fast Lane, which is kind of a whole, 1 or 2 line summary of important papers like things like rivers, and then all the pros, cons, bottom line, what the chart showed. So if you're looking at research in an area, that's a good resource, and it's actually good things out.
7 minutes and 42. Just saying. Any questions?